My name is Ariana Khosrabani, and I'm going to talk about ultrasound guidance used in regional anesthesia in the emergency department. So a little outline of what I'm going to talk about. So what is regional anesthesia? It is the anesthetic technique that is applied to a large area of the body. It can be given either as a single shot or via catheter to be given continuously over a certain period of time. The patient will be awake instead of when you go under general anesthesia, but they can be sedated, and this allows for less side effects like nausea, vomiting, hypotension that you usually see with general anesthesia. What are the indications for this? So anesthesia prior to a procedure, it's especially helpful in patients with contraindications to general anesthesia, or specifically in the emergency department when pain control is necessary secondary to an injury or prior to a procedure in the ED. It's also used as post-op pain control and can be left in at the end of a procedure if it was used as the mode of anesthesia in the first place, or it can be placed at the end of a procedure prior to a patient awakening. So, using the peripheral nerve block in the emergency department eliminates any need for airway monitoring, post-procedure observation, and it also eliminates the risks of general anesthesia, such as anesthesia and sedation, like hypotension, nausea, vomiting, anaphylaxis. There are many uses for this type of procedure. You can use it for acute pain management. You can use it in procedures in the ED that are common, such as joint dislocation reduction, fracture reductions, and then wound care, including lacerations and infections that might need to be debrided. Contraindications to using a peripheral block would be allergy to local anesthetic, infection at the site, compartment syndrome, extreme obesity, and any kind of coagulopathy or use of anticoagulation. So why use ultrasound guidance? There are decreased complications. So when you have a difficult block, such as in obese patients, a patient with abnormal anatomy, or patients such as pediatric patients, there's also a decreased rate of pneumothoraces and upper extremity blocks. Usually this occurs secondary to proximity of the pleura in these procedures. One study particularly showed a decrease in pneumothorax from 6.1% to 0.6%. You also have a decreased incidence of complications such as vascular puncture and hematoma. You have an increased efficacy of blocks, so less time to block and improved quality of a block, and you typically get both sensory and motor blocks when you do it with ultrasound just because you can monitor the spread of anesthetic better and make sure that it's placed appropriately. It also reduces the amount of anesthetic needed in terms of volume. Again, you can accurately assess the volume you're introducing using the ultrasound, as well as, like I mentioned before, the location and spread of the anesthetic. This way you have a lower incidence of systemic toxicity. You have less procedure-related pain, and it's also more cost-effective. So the general technique for a peripheral nerve block is to use high-frequency linear probe of 5 to 10 megahertz. This is a type of probe like this is best used for superficial structures. Nerves will typically have a variable echo texture. So the general rule of thumb is that the fascicles are hypoechoic, meaning darker, with hyperechoic peri and endoneurium that gives this like honeycomb-like appearance in the transverse plane, and that's what you can see right here. Nerves are typically anisotropic, which means they have a difference in echogenicity depending on the angle of the ultrasound beam. So a lot of times you might want to rock back and forth to kind of get the best view and see what position you get the best view of the nerve in. But basically you're overall looking for a hyperechoic structure. Again, in terms of a general technique, you really need to know your anatomy and your landmarks, and ultrasound can kind of help you with that if you know what you're looking for. So you're identifying structures that will guide you to finding your target nerve, as well as structures in the vicinity you would want to avoid puncturing. Sometimes it's helpful to trace from the distal area of the block, given that nerves change their morphology as they run and can be difficult to identify or distinguish from similar-looking structures. A lot of times it's good to keep in mind that they often run along or between muscle group borders and borders of other structures. Basically, the important thing is you're going to be adjusting the angle of the probe in every axis, and even slight changes can make a large difference. And like we talked about before, that's important with the anisotropy. It's important to distinguish nerves from vasculature during the procedure, so you can either check for compressibility and use Doppler, Nerves should not be compressible, whereas vessels will be, again, depending on the kind of vessel, artery versus vein. Veins will be more compressible. And you should also always aspirate prior to injection to make sure you're not aspirating any blood, to make sure you're not in any kind of vessel. You should also distinguish them from muscles and tendons, which tend to be deeper, and you might observe movement of these structures if you move a limb to kind of help you distinguish. Adjustments you can make in terms of the ultrasound machine. Depth will vary with the patient body habitus. So your target nerve should be at the center of the screen, and you should adjust as needed to image whatever anatomic structures you need to see. Again, this is important for your landmarks and avoiding structures you don't want to damage. Here is just kind of a table of different depths you might need depending on the kind of block, whether it's a wrist, a femoral, infraclavicular, and you can adjust accordingly. The other thing is gain. Inappropriate gain can cause a bad image and kind of obscure what you're looking at, so you're going to adjust it based on the optimal contrast that you want between muscles and connective tissue. Muscles should be dim, nerves should be bright. So another big topic in general technique is, are you going to use an in-plane versus an out-of-plane technique? An in-plane technique means you place the needle in the plane of the ultrasound beam, so you visualize the needle shaft and tip in real time, which is what you see here. You see the whole needle shaft and tip. Out-of-plane means you insert it perpendicular to the transducer, and the needle can only be visualized in cross-section. And movement of the tissue by needle and injection will confirm localization. So you can see here, this is the needle tip. So you just see this tip right here. So with a femoral block, you would use this to block anterior thigh, femur, knee, and get skin anesthesia over the medial aspect of the leg below the knee. It's useful in procedures of the anterior thigh and knee that do not involve the posterior leg. Commonly performed with a sciatic block if the posterior leg needs to be covered, and this is very useful in the ED, in particular with hip fractures. So how do you do this? You lay the patient supine and you place the probe inferior and parallel to the inguinal ligament as shown in this schematic, and you want it transversely in the femoral crease, as you can see here. Basically, once you've placed it, you need to locate the femoral artery and vein. You can use Doppler to help you do this. Again, the vein will be collapsible. And just remember your naval acronym. The nerve will be lateral to the artery. It could be below the iliopsoas fascia, lateral and inferior to the plane of the artery. You want to stay proximal before the femoral artery bifurcates in this situation. And then the nerves will be arranged in a pendant flag shape with the base at the femoral artery and extending laterally, which is kind of illustrated by this right here. So what you want to do is use a lateral to medial in-plane approach. You can use 20 to 30 milliliters of 0.25 to 0.5% Marcaine or 1 to 2% lidocaine. You want to use a 20 or 22 gauge 3.5-inch spinal needle, and you want to enter with the needle bevel up 1 centimeter lateral to the probe. You're going to target hyperechoic fascia iliaca over the iliopsoas muscle 1 to 3 centimeters lateral to the nerve. Like I mentioned before, you always want to aspirate to confirm location. And then at that point, you're going to inject 3 to 5 milliliters of anesthetic and watch the hypoechoic injectate in real time to make sure it's where you want it and appropriately spreading. You should see the fascia iliaca move superiorly toward the skin surface, so this area right here. And then you'll continue to inject 10 to 20 additional ml and 3 to 5 ml aliquots. You stop anytime spread is not visualized because you worry about intravascular injection and check the patient for symptomatic signs of intravascular injection. So basically what you're going to do is inject anesthetic 1 at the level of the pendant flag here, just lateral and even in depth with the common femoral artery, so right about here, and then deep to this location, so about here, and then lateral to the tip of the pendant flag, so here. How do you evaluate the efficacy of a block like this? So with hypoechoic anesthetic, you should see that appearing, and then you should see it displacing the nerve anteriorly, and then it should track distally with a circumferential pattern around the nerve, which you can track by tracing the ultrasound probe distally. The onset is usually 15 to 25 minutes, and duration is 3 to 8 hours. In an axillary block, you would be blocking the forearm, wrist, and hand, and elbow if the musculocutaneous nerve is included. This is ideal for the ED because you avoid the complication of a pneumothorax, which is more common in some of the more proximal nerve blocks, and it avoids the complication of phrenic nerve paralysis, which is better for patients that have respiratory comorbidities. Again, the patient will be supine, and their arm should be abducted 90 degrees and externally rotated as shown here. The probe is placed transversely on proximal medial upper arm with the indicator towards the biceps on the right and if you're on the left arm, towards the triceps. Next, you should identify the coracobrachialis and biceps. And then you will be able to identify the axillary artery. So as shown in this diagram, you have the muscles here and then the artery here. The axillary artery will be superficial to the humeral reflection between the two muscle groups. It should appear pulsatile, and you can use Doppler if necessary. The median nerve will be lateral between the axillary artery and the flexor compartment, so here, more laterally. The radial nerve lies posteriorly and deep to the artery, and then the ulnar nerve lies medially opposite from the median nerve, so over here. And then the musculocutaneous nerve is within the flexor compartment, so that will be here. The needle will be inserted over the biceps. You can use a 5 centimeter long 22 gauge or larger needle. Again, using an in-plane approach as demonstrated here. Each nerve should be bathed in local anesthetic, and you will be using about 20 to 40 milliliters of anesthetic total. If all the nerves cannot be seen at once, which is the ideal way to do it, then you should block the median nerve first, as shown here, and then pass the needle between the median nerve and the artery to target the ulnar nerve here. Then withdraw the needle and insert towards the inferior border of the artery to block the radial nerve here, and then redirect it to hit the musculocutaneous nerve here within the muscle compartment. Again, aspirate before to confirm location. You want to watch for the injectate to surround nerves to make sure you're not intravascularly injecting. Evaluating the efficacy, again, you watch for that hypoechoic anesthetic to displace the nerves from the axillary artery. The duration is about 8 to 24 hours depending on the volume used, and you might even need as little as 2 to 8 milliliters per nerve. The last block I'll talk about is the popliteal sciatic nerve block. This targets the foot and ankle, gives you skin anesthesia over the posterior lateral portion of the lower extremity distal to the knee. The medial lower extremity is innervated by the saphenous nerve, so you can consider a concurrent femoral block in addition for injuries of the whole distal lower extremity. An example of this would be like a bimalleolar fracture. It's indicated in foot and ankle procedures and in analgesia. Local infiltration of anesthetic to the sole of the foot is painful and does not penetrate well. And so this is a commonly used procedure in the ED for like a plantar laceration repair, foreign body removal, calcaneal fractures. So again, patient positioning is important. In this situation, the patient will be prone. You need to be using a depth of about 2 to 6 centimeters on the probe, and then place it transversely across the popliteal fossa as shown here. And the probe indicator should be to the patient left. You identify the femur, and then the popliteal artery and vein are superficial and medial to the femur, so as shown here. The sciatic nerve is superficial in the popliteal fossa. It's between the biceps, between the long head of the biceps femoris laterally, which is here, and then the semimembranosus muscle medially over here. Again, this will be the area of the bifurcation, and these nerves will be superficial and lateral to the popliteal vessels. So as you can see here, common peroneal and tibial, and you will follow them proximally to where the sciatic nerve is formed just before they bifurcate. If you have a difficult time finding these nerves, you can do the seesaw sign, which basically the patient dorsiflexes to find the tibial nerve and then will plantar flex to find the common peroneal nerve. Again, it's an in-plane technique. You'll advance the needle into the epidural sheath between the tibial and common peroneal nerve, and you will hear a click. Again, you want a heme-negative aspiration, and you'll inject 5 to 10 milliliter aliquots to surround the nerve circumferentially for a total of 20 to 30 milliliters. The fastest block is achieved when injection separates the tibial nerve and common peroneal nerve. And then you can scan cephalad to confirm adequate spread around the sciatic nerve itself. Onset is about 30 minutes, and duration is 6 to 18 hours. So just a quick outline of what we went over. We went over what anesthesia, regional anesthesia is, how it's used in the emergency department, why you would want to use an ultrasound machine to do it, and then the general technique and some specific block techniques. These are my references.